Great. Why don't we go ahead and get started? It looks like we'll probably still have a few people rolling in as we get going, but I want to just be mindful of everyone's time, and we've got a lot of really fantastic information to cover. So good morning, good afternoon. Welcome to the Housing Focused Mobile Outreach webinar, which is being put on by CSH. Next slide. So CSH, if those of you who have not heard of us, we're the Corporation for Supportive Housing. We are a national nonprofit working across multiple states. Oops, you could go back. Yeah, working across multiple states, really influential advocate for anything related to supportive housing. We provide training and education such as what we're offering today. We do a lot of policy work. We also do a lot of consulting and technical assistance. That is what is funding today's webinar, as well as we're a lending institute. We're a CDFI, a Community Development Finance Institute. So that's a little bit about CSH. And next slide. We are also part of a national training and technical assistance partner. There are 21 NTAPs that are funded to provide this type of TA and training to federally qualified health centers and lookalike FQHCs. And so this is just a brief list. So we really work, a lot of this work is at the intersection of community health, public health, housing, and recovery. And so we're really excited to be bringing information about street medicine and mobile outreach today. So my name is Tom Stubert. I'm a senior program manager. I'm sitting in the San Diego office of CSH. I have been working on the HRSA line of business for the last probably 5 to 7 years. Those slides just have a mind of their own today. And I want to turn it over to my colleague, Jamie, to introduce herself.
Hi, welcome everyone. My name is Jamie Blackburn. I'm a senior program manager on our federal technical assistance team. I'm the lead for our HRSA, that's the Health Resources and Services Administration Bureau of Primary Care funded technical assistance work. This discussion today is brought to you with funding from HRSA, so we're very grateful to them for this opportunity and just wanted to say thank you. And hello, next slide, please, Kathy. So much. And I just very briefly, because I want to get to our panelists as quickly as we can. We're so excited to have them here with us today. We wanted to offer this opportunity for a discussion around creating and launching housing-focused mobile outreach programs for health centers, given the sort of availability of new funding that was part of the American Rescue Plan that provided new opportunities for health centers if they were interested in purchasing items and things that were necessary, the funding necessary to launch some of these programs or maybe to support existing programs. And so we are so grateful to have some of our partners here today that are running really, I think, excellent examples of national best practice. And so we're very excited to have them here today. And then just as a few quick housekeeping things, please keep your questions coming. We want to answer them live time. We have a lot to get through today, so we don't want to save them till the end. Happy to answer those questions as we go. And if you are interested in receiving some more direct one-on-one TA from anything that you've heard about today, want to dive in deeply, answer some questions one-on-one, I will be dropping our contact info in the chat. We are funded to provide that one-on-one technical assistance from HRSA. If you're interested in that, please reach out to us. Great. And so I just want to allow our panelists for today to introduce themselves before we jump in.
Good morning, everyone. Let's see, next slide. Oh, you want to do the introduction? Sorry.
Yes.
Sorry. Yeah, I'm the Assistant Director of Medical Services at Father Joe's Villages. I project manage and develop the street health program. It's really becoming a program at this point. I lead a team of advanced practice clinicians as well. I'm an ANCC board certified family nurse practitioner, and I've been a nurse practitioner for about 13 years. And I've provided healthcare services to diverse communities in California, Hawaii, Georgia, and Alaska, primarily in fairly qualified health centers. and I'm a dedicated healthcare health equity practitioner. And I truly believe that street medicine is a solution to move closer to health equity. I'm also very passionate about DEI, diversity, equity, inclusion initiatives, and I'm an active member of CPCA. Maybe someone in Sacramento might know about the CPCA, supporting Black Communities Work Group, and also previously the Health Equity Group, and also part of the Association of Clinicians for the Underserved, the JEDI Committee. So very dedicated to that. And one fun fact, I've published 3 coloring books, and sometimes I share those coloring books with our individuals experiencing homelessness to provide some meditative quality.
And I'm Thomas Steenblock. I'm the site administrative director for mobile healthcare services for Open Door Community Health Centers. We're in the northwestern corner of California. I'm a graduate of the Clinic Leadership Institute through UCSF. I've been with Open Door for 16 years. I started as a medical assistant and have grown in my career. I have a real passion for the type of thing we're talking about today. I myself am formerly homeless and a person in recovery. And so many of my life experiences informed my mission orientation. The Open Doors particular orientation and organization has always been to work with the underserved. I represent Open Door in multiple public forums, both nationally and locally, regarding issues for the care for the homeless, substance abuse, and psychiatric care. I have worked in almost every department at Open Door at one time or another, everything from operations to frontline as a medical assistant, as well as working in administration and program management. I'm also one of our grant writers and work extensively with our HIV program. I'm the manager of our Ryan White funded HIV program, and where all of these things intersect. And I'm extremely excited to be here and to be able to share with you the successes we've had at Open Door and our challenges today.
Maylee, you're on mute.
Oh, the running line, right? We're on mute. So I'm, well, I already introduced myself. So I'm going to talk to you about street health program at Father Joe's Villages. Street health and street medicine are interchangeable, and I don't have any disclosures. I'm going to split this conversation into 2 parts. Part 1 is really moving into, next slide, some of these objectives. So we want to define what street medicine is and the philosophy. I'm going to go through the goals of street medicine. Can you back last slide? And then number 3, going through identifying strategies delivering care on the street, describing the current state of street medicine, and then describing the conditions specific for starting a street medicine program. So we're going to start with the objective, the first objective, defining street medicine and philosophy. Next slide. Okay, street medicine is defined by the Street Medicine Institute as including health and social services developed specifically to address the unique needs and circumstances of the unsheltered homeless, delivered directly to them in their own environment. In the background, you can see our team here: Sheila, Jenny, Kristen, Serena, and Josh. And behind that is our van, our Betty. We call her Betty for Betty Ford. Next slide. So defining street medicine at its basic core, we serve individuals who are experiencing homelessness. They are unsheltered, they're not in a sheltered environment. And we provide medical services to prevent medical conditions from deteriorating to the point of needing emergency care. As we all know, oftentimes individuals who are experiencing homelessness end up using the ER quite a lot. And how? Well, we are a multidisciplinary team. We provide a variety of services, including medical, behavioral health, case management, and basic humanitarian care, like food and water and other items. And we provide medical care directly on the streets, in encampments and in parks, under bridges. And really the why is because a lot of these individuals tend not to access traditional healthcare services as many of us do or expect to. Sometimes the traditional medical model is traumatic for a lot of individuals who are experiencing homelessness. Next slide. So the basic core and the philosophy of street medicine is go to the people. This was quoted by Dr. Jim Withers, who is considered one of the founders of street medicine in the US. And that was me in the background. So I like to split up the street medicine philosophy into 3 buckets: people, the care delivery, and the advocacy component. So people, we want to meet people where they're at. We don't want to assume all the individuals out there are the same. We do not think of them as a monolith. And we focus on building trust-based relationships. And we want to have a very human-centered approach in all that we do. The streets are humbling. And our care delivery model is really to go, listen, and act. And we deliver care according to the circumstances that are out there. We let the streets teach us. We build the program based on what's out there. And we do not look at things as a menu of services. Rather, we look at the street as being the strategy. We create choices for people. We are consistent and recurring presence. That is the key component there. If it's once a month, that is not street medicine. That is not the type of services that we provide. And we want to keep our teams multidisciplinary. And it's important to fight the retreat from the streets. And what that means is that there's a continuum of services out there. There's backpack medicines where you are walking the streets and you're reaching out to people directly into their sleep environment. And there is mobile medicine where people come to you. This is not mobile medicine. This is not an RV. This is not a big operation where people come to you for services. That is mobile medicine. And we provide trauma-informed care. We recognize the structural trauma of traditional care systems. We recognize the competing priorities out there of individuals. You know, they have a lot going on, you know, and we can't ask them to operate in a certain way. We can't expect them to. We have to see what they're capable of, you know, based on their circumstances. They're out there in survival mode. And we have to recognize the rules that people are working with rather than the rules that we're working with. And the last bucket is advocacy. So street medicine is a tool towards achieving health equity, justice, and peace. Next slide. The core of our service is really building relationships. And I want to quote Lucy Caston from Alameda County. It became less about the immediate delivery of services and more about building trust. For folks whose lives are so unpredictable, knowing there is a space every week for them to talk to the team allows for that relationship to build over time. And that is exactly what we do, building relationships through time. Next slide. Also, health equity, I just want to point it out. The CDC states that health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving the potential because of social position or other socially determined circumstance. So we look at all of this. We look at their length of life, quality of life, rate of disease, disability, death, access to treatment, and severity of disease. Next slide. The next goal is to identify the goals of street medicine. Next objective. So the goals of street medicine are really to break down the barriers to healthcare access. A lot of people out there may have health insurance in some form or another because maybe they've accessed the health system through the ER, but they have a lot of barriers in following up. And we want to provide the highest quality of care out there. You know, if we can do it, if the nurse practitioners or PAs are licensed to do it, then they should do it. You know, we do not want to create barriers for individuals. I know in some street medicine programs like USC, they do ultrasounds. We don't do ultrasounds, but you know, if we found that our streets were telling us that we needed ultrasounds, then we would try to build that. We want to prevent unnecessary emergency department visits. That's a big goal, right? You know, there's high cost involved in individuals going to the emergency department. And, you know, at some point, you know, there's only so much people can do. And to the next level, people in the ER start to feel some moral injury from not being able to help individuals who are homeless, right? They can only do so much. They're only given certain tools that they can operate with. And, you know, it kind of hurts, right? If I was working in the ER and I couldn't do something for someone because that level of service isn't available to them for what they need, housing, food, social services, then it's not a good place to go. And we want to reduce morbidity and premature mortality. We want to improve the access to resources like housing at the core, income, supportive services, and we want to foster ongoing engagement with primary care and behavioral health services. Next slide. Next objective is to identify strategies to delivering care on the street. We want to focus on three main things: safety, people, and partnerships. Next slide. So as far as team safety, there's a lot of discussion around this because, first of all, we have an all-woman team. In the previous photo, you saw a male as one of our outreach workers, but that individual has since gone to another team in the security team. So, but I want to explain that a little bit. So team safety, you know, basic standard precautions still apply out there, you know, and situation awareness is critical, really understanding what's going on in the street before you really go deeper into the street. Self-care practices, when people are burned out, they tend to react versus respond. We also use verbal emergency phrases. We use like green backpack to say like, we're in a dangerous situation, let's get out. We want to avoid language that could create triggers for individuals out there. We have fundamental safety actions that we discuss on a regular basis and evacuation plans. For patient safety, we want to care about, you know, delivering harm reduction to individuals, teaching them harm reduction. We want to make sure that we come in peace and we are there to serve them, and we come with a humble heart and a humble presence to say, you know, is it okay if we, you know, help you out with that wound on your arm? And we always ask for permission. So always respecting the individual and their space. That's their sleep environment. That's their home. Next slide. Safety. Oh, go back. Safety. So we see medicine as an instrument for peace. And as you know, the human connection out there is also a tool of security. Which, you know, it's really hard to explain that. And I know that Brett Feldman, who is the director at the street medicine and, you know, the street medicine team at USC, has really tried to dive deep into explaining that component and how the human connection is a tool of security and safety. And building rapport with clients keeps everyone safe. And identifying lifeguards. Now, lifeguards are individuals out there that take care of the community, their encampment. And there's a bunch of them out there. You know, they want to make sure their encampment or area is taken care of, and they see a medical team. Well, they, you know, that's your guide into an encampment. Oftentimes police or security presence can be re-traumatizing. So we don't want a security guard with us. We don't want someone that looks official and looks like they might be carrying a gun or a knife or something. We want to be out there in solidarity with those individuals. The street is a great equalizer, as Corinne Feldman has quoted. The next slide. So our mission at Father Joe's Villages is CREED, compassion, respect, empathy, empowerment, and dignity. And this very much aligns with some of the philosophy and mission that we have, is that we want to find individuals who are lifeguards or intermediaries, those individuals that support their own encampments, that are kind of the leads of their community out there. When we're out there, we are a flat team hierarchy. No one is above anyone. You know, the nurse practitioner isn't much better than the outreach worker. Like, it doesn't work that way. Everyone has a role and everyone is going there with humility. And we always go with curiosity, because if we don't listen out there, we're making assumptions about what people need. And that's not the approach we want. We use motivational interviewing like most places, and we use the house beds model. Next slide. The house beds model is something that was published by Brett Feldman and Corinne Feldman from USC. And this helps to create, kind of a listening tool. It's a listening tool to really understand what's going on with individuals out there, and really to help identify what assets do people have and how can you work with those assets to help individuals, access services or get off the streets and get into a shelter and that sort of thing. And I'm happy to share the link later on house beds. Next slide.
I wonder if I could just jump in real quick. We have a question in the chat from one of our participants who asks, as an FQHC, we can only provide treatment services in places diagnosed in Form 5B. Is there a special provision for FQHCs doing street medicine?
I don't know what Form 5B is, but I can tell you that we provide as high level of care as we can out there on the street. I know there's a lot of hindrance with a lot of, I don't know, I have not seen Form 5B, maybe I should, but we deliver care that's needed out there. Right now in the state of California, what state are you in, Fundisani?
I'm in Alabama.
Alabama. Oh, got it. Okay.
Yes.
Hello, Alabama.
Hello. How are you?
Very good. So I'm in the state of California. In the state of California, we have just received the ability to bill for services out on the street. And so that is the most wonderful thing. And we're trying to push that out with some advocacy into all states. So really the next step is really trying to push that out and seeing how we can bill for services for street medicine.
It does say, and I've linked this in the chat if folks are a little bit want to dive into the details a little bit, but it is the BIPIC HRSA, more information around Form 5B service sites, but it does say that sites may be identified as permanent, seasonal, mobile van, or intermittent as described. So I would encourage you to dive in a little bit more on that, and also happy to talk more offline as well.
Thank you.
You're welcome.
Thank you.
Right. You're welcome. Foodie Sunny. That's a great name. So our partnerships really are really critical. You can't work in a silo when you're working in street medicine. We work with the city, the county, and the community. And the reason is because we increase access to resources for clients. What we don't have, we can find something, right? We can see if someone else is an expert. And oftentimes we find that is the case, you know. Father Joe's Villages is known as a one-stop shop because we do deliver a lot of different services, but we can't do everything. And, you know, some partners out there have better strengths out there, and it helps to reduce cost. You can't build it all. It helps us to share resources, coordinate care, and increase our chances of success. So it's great to be collaborative out there. Next slide. Fourth objective is to describe the current state of street medicine. So a lot of things are happening in street medicine. I wouldn't be able to summarize it all, but this is kind of like some of the main points. There's a lot of residency programs that are trying to incorporate street medicine as a component to the residency program. Right now, USC Keck School of Medicine and JPS in Dallas-Fort Worth area are the only two who are actively have a part of their program that is street medicine based. The other thing is providing medication-assisted treatment with Suboxone out there, doing inductions out there. That's something that we have started recently. Street psychiatry, a little more common in Northern California, as I've seen, less common down here, but we are actively working on starting a street psych program here. Recuperative care. Recuperative care and its link to street medicine is like a perfect dance, because the nurse practitioner out there and the team out there will be able to identify individuals who really won't do well recovering from an illness out there if they're not in a shelter. So recuperative care, linking that, finding a partner in the community with recuperative care is critical. DEI should always be included, diversity, equity, inclusion, because it's at the core of how we operate. It's at the core of the philosophy of how we operate. And billing for services, as I mentioned earlier, in the state of California, DHCS has allowed us to bill for street medicine services. Next slide. Question, Donna Sennett. How do you address respite beds? I have several unhoused patients who need surgery, but the doctors don't do surgery if there's not a specific housing option following surgery. As a result, unhoused persons go without the surgery. Shelters, even if there were beds, will not accept medically compromised people. Yes, very difficult. Father Joe's Villages did start a recuperative care program, and even we have a hard time putting individuals in our recuperative care program because insurance companies have all these like barriers, right? I call them barriers because maybe you have to be part of the health plan for 6 months, or maybe you have to have like 6 ER visits before you can get into recuperative care. And I feel like there's a lot of red tape all across everywhere. I think all of us are facing that. So yeah, I don't have a good answer for it. So I think it's a struggle forward. Where was I on this slide? I saw it like flashing. Okay, so objectives for the 5th objective is describing the conditions specific for starting a street medicine program. Next slide, please. Next slide, please.
I lost the slides.
Okay. And thank you for your answer, Jennifer. We have 28 beds.
Hold on. Jamie, can you take over for a minute?
Absolutely. I'm happy to do that. If you can give me,
Trying to get back. I'm not.
I do apologize, everyone. I'm having a slight technical difficulty.
Yeah, so our recuperative care program at Father Joe's Villages takes all the insurance plans in San Diego County, but yet, you know, it's still very difficult because each health plan has their own criteria, which makes it very difficult to really manage that. It really takes someone who knows how to navigate that whole space to get people approved into that program. So, okay, yay, next slide. So starting a street medicine program, you want to look at all the components of a program. What is the community need? What is the target population? Where's the area of service? What's the team composition? And how will you engage with individuals? Next slide. Okay, so some of the tools that we use is design thinking and systems thinking. I strongly encourage that. It's a very human-centered approach to figuring out what is really needed in your community, and always making sure that we use the framework of social determinants of health as part of our toolkit. Next slide. So design thinking is a reiterative process. It's continuous, it's messy, but really at the core are these 4 principles. Build innovations around experiences, think of innovations as systems, cultivate an innovative culture, adopt a disciplined innovation process. So really, it's really learning to understand what's going on out there in the street, talking to people, and explore and figure out if you can pilot things and test it out, and then implement them and see if they continue to work. If they don't, then you have to reiterate and really understand the problems. Next slide. Systems thinking. I'm going to skip this slide. Sorry, I want to make sure I get to some of the videos that I wanted to show you all. And we all know the social determinants of health. I'm going to assume we all know those. And next slide. So community need, target population. When you're innovating, these things are messy, right? Like what are the problems? What are the assets? What are the needs of the people? How will you engage with all the different individuals and all the different entities out there? Next slide. So one innovation project team that I've had a journey with is Karen McCabe, Director of Community Programs Development at Scripps Mercy, and Hanan Scraper from PATH, Regional Director. And part of our team, well, what we decided was that, the ER has a lot of individuals that are homeless. And what do? There's nothing to do, right? So how about referring them to our street health program? How can we do that? How can we figure out how we create that that process, or will it work? So we spent about 14 weeks discussing this, identifying the problems. We interviewed over 100 people all throughout, our respective spaces. I interviewed a lot of people in California, and a lot of individuals doing street medicine. And yeah, so what we came up with was a 2-week pilot where individuals are referred to street health, and then we go find them. And there's a lot of problems that can come up, like, well, we can't find them. Well, how about we do a video chat with them while they're in the ER? Okay, that worked. Okay, so it's really testing out what you can do to help find these individuals and prevent them from having to go back to the ER for whatever needs they have. Next slide. So starting point, team composition. what will be the best for your clients. If you don't have a lot of substance use disorder out there and you have more mental health issues, maybe you focus more on street psychiatry. If you have more medical needs, like we have a lot of wound care out there, then we probably need more of a medical based team. We do have a lot of substance use disorder out there, and so we have an alcohol and other drug counselor on our team. And engaging with your clients, what tools of engagement do you have? Next slide. So team composition could be a registered nurse, a band practice clinician, physician, medical assistants, occupational therapist. This is kind of like ideas, right? It could be anything. You'll find it out. Occupational therapist, probably not fitting for our team, but it's fitting for USC, right? And Alameda Healthcare, I think, does more psychiatry. So they have more of the behavioral team members. And then the outreach worker, you always need outreach workers. You always need some kind of community health worker, or outreach worker, or social worker in that space to really connect individuals to services. Next slide. Tools of engagement. So there's a lot. Urgent care, we do prescription dispensing now. We do medication assisted treatment. We do AOD counseling, harm reduction. It's a slew of services. And really the core of it all is just having the variety available so that when we meet somebody, we can engage with them and say, oh, wow, you get a few bugs in your hair, do you mind if we take care of that for you? And we can shave off their hair if they want us to. We've done haircut rounds. And, we always start off with a supply, right? Like, do they need water? Do they need food? And it's really the primary tool of engagement, water and food. And sometimes they'll say, hey, do you have any Band-Aids? Yeah, Band-Aids. Where do you need the Band-Aid? Oh, you need that on that big wound. Okay, well, how about we give you a bigger Band-Aid for that? And, we just engage when, based on what they're ready for, right? And the resources that we use a homeless management information system to really track our clients out there, make sure we're able to find them and see what kind of services they've accessed. And we have a coordinated entry system in San Diego County. We have our outreach phone that we give out to individuals. We actually have a little street health card, and I'll kind of show it to you on my screen here. And it's got the outreach numbers. I know it's backwards, and it's got our Betty band. So people recognize us by our band. Next slide. The second part is really kind of getting into the history and introducing you to some key players in street medicine. We'll go through this whole outline, the founder, the trailblazer duo, the history of street health today, and some storytelling. Next slide. Okay, so the founder of street medicine is really considered to be Dr. Jim Withers, who is out in Pennsylvania. He coined the concept of street medicine in the 1980s. He founded the Street Medicine Institute in 2005. And it's really, he's coined the term classroom of the streets, right? It's the streets teaching us what is needed out there. It's reality-based medicine, as he says. Next slide. Brett Feldman is really one of the trailblazers. He's out at USC, Keck School of Medicine. He has started many street health programs, street medicine programs. Yeah, we're very good friends with them, and they come down and visit us all the time. Next slide. And this is his wife, Corinne Feldman, who does more of the publishing and educates residents and medical students and more of the didactic piece of street medicine. And Corinne is pretty amazing. She just gave her first like full like education, like fundamentals of street medicine at the 4th annual LA Street Medicine Symposium in Los Angeles. So that was really great. I really recommend that conference. It's once a year in August. Next slide. And the history of street health here really started in 2018 when we recognized that, San Diego was had the 4th highest number of people experiencing homelessness. So what was the problem? Like if we had this many people, but we had no street medicine, and people weren't coming into clinics, this was a huge problem. So there's a lot of unmet need and a lot of barriers to healthcare. How might we fix that? Well, street medicine. So in 2019, resources were identified, services were determined. There was some investment in a van with HRSA funds, and then the street health program was launched. Next slide. And then this is our founding team: Dr. Jeffrey Norris, Megan Parsh, and Kristen Horney. Our chief medical officer, he really provided the vision and the strategy, and I misspelled the vision, apologies. And Megan was really developing that strategy, and implementing and executing was Kristen. Next slide. And this is the video.
Yeah, hi, my name's Jenny Wilkins. I am a drug and alcohol counselor with our outpatient program here at the Village Health Center. And I also join the street health team as a drug and alcohol specific outreach worker.
My name is Joshua Sanchez. I've been working with Father Joe's Villages for over 3 years now. Was previously the supervisor of security, and I have been recently moved over to the Village Health Center as an outreach worker working with the street health team.
Horney. I'm a nurse practitioner at Father Joe's Village Health Center and part of the street health team. I've been doing this for about three years. I did 3.5 years, took a 2-year break. We moved away, but we're back. I'm very happy to be back and part of the team.
Yes, was born and raised in San Diego, so I know the area pretty well. I went to both my undergrad and grad school here, and I've been at Father Joe's about 2 years. Great. I've been a nurse practitioner for 15.
Awesome. Next slide. How's the program funded? We get grants and donations. And now, since we're able to bill for services, we are able to start subsidizing our work, right? So we started off with grants and donations. So I'm going to skip the street health history, actually. We can kind of just skim through this. Yeah, there's a lot of history I could go through, and a lot of things have developed from there, but I want to make sure I get to some of these videos. So why is street health important for persons experiencing homelessness? Oh, it skipped. Thank you.
The patients that we see are on the fringes of society, and a lot of times they have mistrust and they don't have regular hours, so to speak. So going to them gives them the opportunity to have some health care. Otherwise, they kind of neglect that portion of their lives.
There's many individuals who have perceived barriers between themselves and the resources that they have available. And sometimes they feel like health is probably like the last of their concerns, especially living out in the street. They have many concerns, like where they're going to sleep at night, where they're going to eat. So street health and the services that we provide them is a great resource and a great tool to get to individuals who are hard to reach or who do not want to come into a door or a brick and mortar to get the help they need. So, yeah.
Street health is important because there's so many challenges and barriers to people, especially our unsheltered neighbors, accessing healthcare and other resources. I mean, there's immobility issues like physical immobility. There's transportation concerns. People can't leave their things unattended for fear it may get taken. And there's so I think it's important that we are out there and we are talking to people and having conversations and bringing the services to the people that otherwise can't necessarily come to us.
I think the overwhelming and obvious answer is because there is a need for it. We have patients that are outside the door, down the street, 100 yards away from the clinic that will not come in and seek care for one reason or another. And a lot of times these people will get so bad medically that they end up in the ER or admitted. And these are things that could have been prevented if we could have engaged them sooner and taken care of them and folded them into the healthcare system sooner.
Okay, so our team today is really the structure of the team is a nurse practitioner, an outreach medical assistant, an AOD counselor, an outreach worker that is hybrid with our day center. Our day center provides humanitarian care, like, place to store things, wash clothes, like have some shade, take a nap, food, access to food and water. And then we have an outreach worker that is clinic-based, kind of like your community health worker. So those two work really closely together. And as I mentioned before, we're working on developing a street psych program. And next slide. And this is kind of where we operate. If you know San Diego, everyone knows the airport if you've been to San Diego. So if you're ever in San Diego and see the street health team, wave. Next slide. This is kind of like this is a business model. If you ever wanted to start a street health program, like key partners, key resources, key activities, the value proposition, the relationships, the channels, the customer segments, really looking at it as a business model is really critical to make sure that you have a very sustainable program and that you have a program that can be something that can be replicated and will last a long time. So I'd like to go into all of this, but I want to make sure we get to the final videos. Next slide. And we do have a lot of metrics here. We this year alone, we've seen 638 patients. We also track the number of times we've engaged with people out on the streets, 898. That's with 2 street health teams right now that only go out in the morning. So it's pretty good. Next slide. Okay. And I think this is a video slide.
There are quite a few. Was this guy in his early 20s, and we'll just call him Jay. He was down in Town, an F Street area, which is kind of a bad location. Okay. His blood pressure was 220 over 110 when we first met him. He wouldn't go to the hospital, but he allowed us to kind of start him on some medication and allowed us to find him week after week, and it was taking effect. It was getting better. Then we didn't see him, but then next week we saw him at the convention. And his blood pressure was a little bit better too. We started him on another medication, it got better. And so then after a couple, 3 weeks, we didn't see him at the convention anymore. And then we're heading out to get into the van, which we call the Betty. And there he is. There goes Jay walking by. He's housed at the short-term shelter here. And that we're so excited. And he came in to the clinic like another week later. His blood pressure was controlled. And he was in long-term housing resources, but started with reaching out to find him and care about him on the street. So that was really awesome.
There's an individual who we came across, we'll call her Molly. She's been homeless for over 4 years, never really had any housing prior to that, was mostly staying on couches and things of that nature. We were able to give her some medical attention. She had some tremblers going on in her hand, and we were able to give her some referrals. But then, one of the side things she was saying is that, I'm just tired of it. I'm over this. I don't want to live here on the streets anymore. I'm getting too old, and I'm just done. She was avoiding shelters. She didn't want to be around other individuals due to past traumas. So we were able to get her back into our community queue and get her matched up with housing. And I was able to get out to her today and get her to fill out the application. And so hopefully in the next 10 days, she will get the keys to her house. So to me, that's a success story of an individual who was content to be out on the street, who finally said, I had enough, and we were able to get those resources. That to me is a big success, because now I know that in a stable house with the right assistance, her health is going to improve, and hopefully she can go get on the path to recovery.
In particular, there's a young man that I encountered when we first started the street health team in 2018, I think is when we first started going out. And he was using heroin. We would see him on the street. Young man, 23 maybe, or 24 at the time. And he was using heroin regularly. We would just stop and talk to him, ask him why, ask him if he had a family, if we could help reunite him, if he wanted to be in the shelter, and his answers were no, no, no. He just didn't want that engagement. He wasn't ready. We finally got him. I walked him to the clinic, and we got him started on Suboxone. The next week, we didn't see him. We found him again. We got him in. Then we wouldn't see him. And I remember it was so hard for me because I would get so frustrated. Like, you have your whole life ahead of you. Please come in. And I thought, and I had left not too much longer after that. And I thought we had lost him to care, I thought maybe he had passed away. I wasn't sure. When I came back to the clinic just about a month ago, I walked into one of my patients' rooms, and there he was. And he's been clean now for 1.5 years. He is in a good relationship. He has a job. He's got a family. He is good. And I'm not saying Street Health did that, because he did that work. He made those choices. But we were there to tell him we care. And to see that he is doing so good is absolutely phenomenal.
2 years ago, we were doing some street health, and it was just in the general neighborhood of our clinic. I think we were, a couple blocks away, and we met a couple, and they had just landed in San Diego from Tennessee. They took the Greyhound bus out here, just in search of, something different, some resources, some better weather. And they also had told me that they were staying in the bathroom at the San Diego airport overnight for shelter. And we just continued to talk, and they disclosed to me that they were both heroin addicts, and they wanted to make a change, but they weren't sure how to do it or where to go. And so I told them about our medicated assisted treatment program here at our clinic. And I was like, let me know. Are you guys ready? What do you want to do? And they were like, let's do it. We're ready. And so I literally got to walk them down to our clinic. And I sat with them, and I made sure that they were able to be seen. And they were seen the same day. And, they started our Suboxone program. Now, mind you, they had their ups and downs. They would come in and they would do very well for a little while, and then they'd disappear off the grid, and then they'd come back. But the coolest thing is that every time that they came back to the clinic, they'd say, hey, is Jenny here? Is Jenny here? And they'd want to talk to me, and they'd meet with me, and we'd talk about some of their challenges and some of their barriers. There was a couple times where I had to put them into detox, and then they left early, and then there was a couple times where they both went to detox and they were successful. And again, their struggle and their journey was up and down. But recently, the gentleman called me, and he was like, hey, I just got out of rehab. I'm in a sober living. And he was talking about how his partner was also in a sober living, and they were doing so good. And it was just so awesome, because I've been able to see their journey, witness their journey, be on the journey with them, and just to see them come from where they were staying in a bathroom overnight at the airport to now being in sober living and taking their medications and actually like being happy and healthy and smiling. It's just like one of the coolest things ever. And those are the kinds of stories that make me, continue to keep on doing what I'm doing.
Okay, next slide. Wonderful. So to continue learning about street medicine, you can do some TED Talks. There's a lot of TED Talks on street medicine now. You can look at some videos at National Healthcare for the Homeless, and Street Medicine Institute, of course, LA as well, street medicine. Myself, you can always reach out to me, and I highly recommend the videos that are produced by Invisible People. So yeah, that ends the program for my part. And yes, you can reach out to me on LinkedIn if you like.
Thank you so much for that presentation, and please everyone for your comments. Thank you everyone for your comments in the chat. Please keep them coming. And now I want to turn the floor over to Thomas Steenblock. Thank you so much.
Thank you. And thank you to my co-presenter for her amazing history on actually street medicine and how all this got started and laying so much of the groundwork, which allows me to talk about a few different things. Let's go ahead and advance the slides there. So again, I'm Thomas Steenblock. I'm the Administrative Site Director and Program Manager from Mobil Health Services, our HIV program, helping lead our efforts on Hep C treatment. I also actually am over our acute care clinic, which was an evolution out of our response to COVID-19 and the way it impacted our community. Our psychiatry program, we have a mild to moderate psychiatry program working in partnership with the county mental health entity. We do medication-assisted treatment, and also we are in the mobile services able to do truly integrated behavioral health, and those are all parts of the way we do this. I'm part of from Open Door Community Health Centers, and just a quick background so they kind of see what this is nested in. Open Door Community Health Centers is a federally qualified health center. They were first founded, let's go to the next slide, please, in 1971. And next slide, too, please. And we serve a really diverse community. We are up in the northwesternmost corner of California. Humboldt and Del Norte counties, kind of an area the size of the state of Connecticut, with only about 2% of the population spread out. We have 11 clinics, and as well as spread out across that territory, about 160,000 residents in total. We serve 90,000 unduplicated patients over any 3-year period and 60,000 over any 1-year period. So we're one of the largest single providers of healthcare and other services in the area. And we offer a full range of services: family medicine, behavioral and mental health, case management, lab, drug and alcohol services, and more. Next slide, please. And so kind of where we are, again, is up in that most northwestern corner, where this is an intensely rural area on the coast, just south of the Oregon border. Next, please. And to give you kind of an idea, and hit next again, there we go. The largest center of population listed there is the city of Eureka. It is only 30,000 people, 29,000 people. The two other largest population centers are listed there. The total combined population around the Humboldt Bay is about 50,000, and everybody else in that is spread out throughout the unincorporated regions. Next, please. And so, to tell you a little bit about our area, if you haven't ever been up here or seen about this, we have giant redwood trees. It's a very beautiful area known for its natural resources. We were also at one time known as one of the marijuana growing capitals of the world. At one time, logging and fishing were the primary industries. Those began to dissolve and diminish. In the 1980s, the area has never fully economically recovered or found a new base. Though marijuana growing, cultivation, both legal and non in California, has become a huge part of the economic picture up here and has added to some of the challenges with working with folks in homelessness. Next, please. And so we, along with, beautiful natural coasts, next, please. We also have, a beautiful historic downtown and other districts. And Not very long ago, we were one of the areas we actually were in the top 5 for per capita homeless only a few years ago in the United States. There's been a lot of efforts made around that, but proportional to our population, we have an enormous number of folks experiencing homelessness. And this is actually a very challenging part of California in which to do that. Next slide, please, because we get quite a bit of rainfall. It is very wet, and many of the areas in which the homeless have been forced into, even both the green belts within the urban areas and unincorporated areas, look much like what you're seeing there. That is an actual encampment that was hit by sudden rain and flooding in that area while they were trying to just get by. Next, please. So kind of another picture about it is, again, Humboldt County specifically, where our services are operating, working with the homeless the most. We have a county population of 133,000. According to our last pit count, which we do suspect was very low, we had 1,309 unsheltered and 347 sheltered. So 1,656 total people experiencing homelessness. 54% of those folks live just in the cities of Arcata and Eureka alone. So in a population center of only 40,000. The rest are scattered throughout an area about 3 times the size of Rhode Island. And this doesn't count any of those who are currently in rehabilitation, jail, returning from prison, clean and sober housing, or unsheltered youth. Unsheltered youth alone, according to the Department of Education here, we have roughly 1,400 youth experiencing homelessness and hanging out in very different places and much harder to reach. Our biggest crisis up here, which is we have way less housing and beds than people needing them. The housing inventory is incredibly low. Marijuana industry has had a huge impact on that. Many places that are normally meant for human habitation have been converted by folks into places for growing marijuana and are off the market. We have very low resources, depressed economy. We're one of the highest overdose rates in the state of California, which also makes us one of the highest in the country. 78%, according to our own UDS data, of the people that we serve through our homeless services have a documented diagnosis of moderate to severe mental illness, substance use disorder, PTSD, traumatic brain injury, or other history of domestic violence or other abuse, neglect, and trauma. A lot of our community partners and citizens are working really hard to overcome this. There's been a lot of work and change in the last few years, and we're really excited to be part of that. Next, please. And the way that we got where we are, how did we even get into this? So a number of years ago, a local doctor named Wendy Ring looked around the community, saw this growing problem of homeless folks who either could not or would not access traditional clinics and get care, who were turning up, and she was often seeing them in the emergency room, knowing that if someone had intervened and had been there for them sooner and met them where they are at, they wouldn't need to be there. They wouldn't be dying. They wouldn't be suffering life-altering experiences. And so what she did was originally she packed up a truck full of supplies, strapped a 5th-wheel trailer to it, and started driving around in parking places, whether the city wanted her to or not, and doing services. She eventually applied for and got what was called the homeless, there was homeless services funding through HRSA. And she applied for that grant, and the homeless services grant, was awarded that, got the vehicle you see on top there, a mobile van designed to be a mobile clinic, and started with Mobil Outreach. And that's really where our program began, is in this Mobil Outreach. When Wendy decided to retire, Open Doors stepped up, said, we already serve the homeless in the best way we can at our clinics. This is part of our mission. We will go ahead and take this on. I was part of bringing them on board and making them part of our program here at Open Door, and I've been involved ever since in helping them grow our response to housing and homelessness. How do we really fund these things? So again, we have grant funding. So the homeless services grant was ultimately rolled into our 330 funding and is just part of our general funds. We have that there as a backup, and it partially helps fund our model because that is there. The non-billable services that we provide on the van, I can say that there's money there to support that. All of our clinic sites, in one way or another, do some services for those experiencing houselessness who are willing to walk in and approach them there. And we'll talk about that a bit more. But it really helps us. Hold on just a moment really quickly. Along with that, we also are directly using the license of the mobile van to bill services when we can do them both in the mobile health setting, but also in the street outreach setting. So Two things have happened. One, because of COVID and the emergency declaration in California, we are able to do medical services and bill for them outside the four walls of a licensed building in a way that we couldn't before. The other thing that has happened is the amazing wonders of telemedicine, of being able to use tablets and being able to have a provider who's in the walls. It depends on who's on what end of the thing, and we can use that and be able to bill services directly. There's other ways to look at that as well, including looking at, is a homeless encampment, does that count as a home visit, which is a billable service also as an FQHC, in answer to earlier questions. And then there's other opportunities when you begin to recognize that when you can meet measures in California, as we move more and more into outcome-based medicine, the majority of our patients are recipients of Medicaid funding, and there is a lot of opportunities meeting quality and health outcome measures that allow funding in the background that we can say, hey, we're helping move this work forward with these folks, and that should be attributed to our team and support our activities. Next slide, please. So what are we all about? Well, mainly really laid it out about what it is about, and it's really to meet people where they're at in life. These are folks that are living, really on the fringe of the community. These are folks who have lost their place in one way or another. There's lots of common misperceptions about how people enter homelessness and why. The number one reason that people enter homelessness is losing their home. It's not mental illness, it's not substance abuse, it's not any of those things. It's other stuff. And those problems may be part of that thing, but lots of people have problems with mental illness, lots of people have problems with substance abuse. Those are common across the board and across all economic sectors. The difference is that these are folks who have been impacted in a way socioeconomically that they can't recover, they can't get back, or they've been experiencing it for so long it may be traumatic to try to return to that. I can remember a patient that we worked with for many years, and he had been homeless for nearly 30 years. He had significant health problems and finally agreed to be housed. We were able to get him into housing. And the beginning of his experience being housed was he would wake up in the middle of the night, realize he was indoors, and become terrified because his only previous experiences for so long of being indoors meant he was either in jail and had been incarcerated or was in the hospital. And he would run outside in the middle of the night and hide in the bushes till morning before he would return. And we had to work with him for a long time to try to help him make and navigate that change. And so really looking at how different it is, the experience that folks are having in homelessness, the fact that that is a form of trauma in and of itself, much less the other things that they experience there, what it's like to be faced with constant stigma and pushback from the community, which is really common up here. Homelessness is a very controversial topic. We live in a community that would prefer to not see that this exists at all, that they would like it to go away, not to fix it, not to address it, not to meet it head on, but to have it go away. And of course, the number one solution though to that is housing. If you want to reduce homelessness, provide housing, and then we work with people to make that possible for those who want that and are willing to engage. And that's the other key piece in this, in meeting people where they're at. And I love what was said earlier, and thank you again for that in your team's presentation. It is meeting people where they are with what they're willing and able to do now. And we'll just keep meeting you as long as you want to meet with us. And our job is to throw open doors to create connection. Next, please. So just to show you some quick pictures, and you can just kind of flip through these. There's our van. This was custom built by us for a company to try to meet that. And it is the core of how we do services as we expand into true street medicine and outreach. There's our team standing there in the van. It's actually really large. And we use it as a home base, even when we're doing street outreach, well beyond its ability to get there, simply because it allows us to have a place to go back and process lab samples, which allows us to do more medical services out in the field. It also allows us to, get supplies closer to where we need them and to be more versatile. We're a very rural area, and many of the places where homeless are actually being forced into by local societal pressure and stuff is more and more unincorporated areas that in green belts that we have to literally get into. And so the closer we can bring things to, and the less distance it is to try to get them back to where they either need to be processed, the supplies or the lab tests and everything, it allows us to do more for folks out there. Overall, at its core, we have a full service hub. We have one MD and two FNPs who rotate as the main providers for the vehicle. With them, we have an RN, an LCSW, a program coordinator who's also the intake person, medical assistant, and a licensed phlebotomist. This gives us the versatility to be able to do things both on the van and off the van, out in the field at the highest level. The licensed phlebotomist and the RN are really key when we go out doing that street outreach. We're able to have people who, under their license, either in verbal communication with a provider, written orders, and so on, are able to do more services for the folks that are out there. It also allows a higher level of assessment in the field when the provider can't be there in person, and we do a mixed model of doing this. We have done both the providing of direct services, including the provider going out and doing hands-on. There's times where the provider's on the van seeing patients and doing video visits with the portion of the team that is out remotely doing the street outreach and street medicine. The provider's able to talk to the patient directly. They have a nurse doing assessment, being their eyes and ears and hands, phlebotomists to be able to take samples and things so that we can get them back and try to get the highest level of labs and things to them as possible. So we're able to offer general medical care, family planning and OB, mental and behavioral health services, access to support groups. We have an MAT program, which we're able to get people connected to, social work services, skilled nursing, lab, etc. One of the things about our program is really connections to other services and how we do that. And one of the ways we're meeting people on the street, particularly those that can't always get to the van or can't get to other places, other hubs of services. Our MAT program is group-based and is at a place. One of the things that we also have, along with the mobile van, is a single vehicle, a Subaru, licensed drivers for it, and we invest the money and the time to be able to transport people who are willing where they need to go for many of the other services that we offer, and including for services that we order for them. Maybe they can't get to that imaging center and we really need imaging to take this thing forward. They've been limping for weeks and weeks and weeks. We need to help them with that. We can get them there. And a lot of the time when they wouldn't traditionally go to one of these places, they wouldn't go to a traditional brick and mortar site for services. What will happen is, because one of our team members, where we've developed that relationship of trust, is going with them, they will go and they will engage. And that's been a huge tool. I love what was said earlier by my co-presenter about developing relationships of trust. To be able to offer all of these services, it first and foremost starts there with constant engagement, meeting them with what is your need today. When they come to our team, when our team comes to them, hey, what's going on with you today? Is there anything we can do to help? And that means anything. We had one patient approach one time who we were approaching them and they're like, no, I don't really need any medical services. Or was there anything else we can do for you? Yeah, I'm actually really, really hungry. I missed the free meal today. I haven't eaten in a couple of days, etc. We got him a sandwich, we got him some food and that kind of thing. And we gave him some food. We were just chatting with him and everything. And after he had eaten and he was there for a minute talking, he finally goes, there is something kind of medical that's really bothering me. Maybe you guys could help me with it. My arm has just been hurting for like a week and a half, and I really don't know what's going on with it. Sure, let's take a look. It was wintertime here. He had multiple layers. When we got his layers off, what we discovered is about a week and a half before, he had gone in for some labs. He'd been in the hospital, gone in for some labs. They had drawn blood and someone had left the tourniquet in place for all of that time. There was necrosed tissue, there was challenges and everything. We were able to help him with that. But the important thing to realize here is, for him, until he had eaten and turned a very human corner, he was not able to talk to us about his medical need. And so the key thing is that working in relationship, having multiple resources both available. We have everything from home, camping supplies to food supplies to other things, fentanyl test kits, all of that kind of stuff at hand, because meeting whatever their current need that they identify. That's how their life is working. I have been formerly homeless. Your world isn't about a watch. It isn't about a calendar. It's about, what do I need right now? How am I going to get through today? How am I going to find a place to hole up and not have somebody kick me in my back and steal my stuff, or be moved by the police, or all of those things? And so being able to really have a team chosen as much for their ability to meet their fellow human beings where they're at, and to simply meet them as human beings, as it is for the other skills that they bring to the table, is really the key in how we've been moving it forward. Next slide, please. The other big piece about how we utilize both our actual street medicine and our mobile medicine is its overlap with its associated, there's an associated brick and mortar clinic as well, which is TVSC, stands for Telehealth Visiting Specialist Center, which is a crazy name from our history, but you can't really get a clinic license name changed really easily as you evolve over the years. But what is there is it's also the home of our medication assisted treatment and substance abuse programs with drug and alcohol counselors and so on. We also have our psychiatry program is based there, and we have access for mild to moderate care in psychiatry, and for some people struggling with severe, for the people who kind of move back and forth across the line depending on where they are in their management with that. It's one of the core sites that we have for HIV, Hep C, and treatment, and particularly for the unhoused. And this is where we often utilize that. If we have one of our people go with them and we can offer them a ride and get them there, we can offer them the transportation methods and so on, they'll come and engage. We have behavioral health. We have a high level of case management. So we have social work case manager who specifically works with our van team and the homeless population, meeting their various needs and connecting to high level case management with other community entities. And we have many of our personnel actually have lived experience like myself and are drawn to this work specifically because this is where it works for them and this is what matters. And that also helps foster communication. It's so different to talk to someone about their experiences when you can say, when that happened to me, this is what it was like. That is the beginning often of that relationship. It's not, though, always necessary, because many people have the ability to simply reach out beyond themselves to others. And so we also now have a way of filling the need for urgent care and to try to keep people out of the ED. So we have one urgent care facility in our city here of Eureka. It does not take anybody with Medicaid or Medicare. They take private insurance and money. And so they cannot access there. Our emergency department is incredibly over impacted right now due to a significant crisis at county mental health, and also due to COVID, monkeypox as it's beginning to develop in our area and other things. And the experience there is often not the one that they need. And so we have created, coming off of what was originally our COVID drive-through, we had transformed the telehealth clinic into a drive-through clinic for management of COVID, and we saw over 10,000 unique individuals in less than a year during the first year of COVID. We realized that we can do urgent care in a really good way there. And so what we've done is we've created acute care services that are available to our homeless patients anytime they want. They can walk in, we will get them in, we get them seen, and we meet their needs at the highest level that we can. So along with that is the other key piece of this, and I think that this is where it really touches on housing and healthcare intersection, is our many, many, many partnerships. One of the things that we have done is actually I am representing our Open Door on our local HUD-funded continuum of care. So for those of you who are not experts in the housing field, for HUD-funded programs, one of the local requirements is to have a continuum of care that makes decisions and helps contribute to the decision-making process on how funding will be awarded. We are one of the non-conflicted members. If you could go back, please. We are one of the non-conflicted members on the Humboldt Housing and Homeless Coalition. Forward to the one on community partners, please. And what happens is we are actually one of the folks that does the rank and review committee that allows, that helps determine where funding is placed. So I help represent Open Door's interest in deciding which programs in our community continue to receive funding from HUD and where they meet the interests of the homeless folks that we all commonly serve. I also help represent us on multiple community working groups that work with city government, the police, and other local housing agencies and social service providers in order for us to have a constant ongoing community level communication and collaboration on how to help folks navigate, because it's never just about our services by themselves. And in a place with such a housing inventory shortage and many resource challenges, us working dynamically together on a regular basis has really helped do that. Also, we have a number of housing partners, including Arcata House Partnership, RCAA, and the Youth Services Bureau, and Department of Health and Human Services. They have all worked, especially coming out of the impact of COVID. One of the things that happened here in California was Project Room Key and then Project Home Key. Originally, there was the idea of getting people who were medically fragile, experiencing homelessness on the street and at high risk for COVID off the street, at least temporarily, or off the street when they became infected with COVID-19. And what that has turned into is the long term of Project Home Key, where they are converting old motels and hotels, of which there are many around here not functioning, into actual housing spaces and into permanent supportive housing. And as that's happened, we've become the provider of care who literally shows up in people's apartments, either with the provider in person and again through tablets, so we can be in more places at the same time, delivering those services right where folks are in either rapid rehousing, permanent supportive housing, shelter situations. We've gone into all of those and are expanding our work in doing that while still situating services at local providers. For instance, St. Vincent de Paul, one of our local partners, has a dining facility that has served anywhere upwards of 600 individuals in a single hour for meal services. A lot of the folks are in very scattered campsites, very hard to reach, but they all come together there at certain times of day. And there's a number of us as resource providers that purposely collaborate and work collectively. Everything from our local harm reduction coalition and needle exchange partners to folks that are working in substance abuse, social services, working with the local hospital and transitional programs and ourselves as well, and really putting our and county mental health and law enforcement. There is a local law enforcement team that we have helped encourage and work with. They are the community safety and engagement team. They are led by a police sergeant who is completing his degree as a licensed clinical social worker and has brought that mentality to the way that the law enforcement interacts with them and with all the community partners. They have actually got the record for getting people from homelessness placed in medically managed detox and long-term clean and sober and permanent supportive housing. They have worked actively as a partner with us to try to help address this and they bring people all the time. Multiple law enforcement agencies actually bring people to us and then even ask us to come with them when they have to go to an encampment that's illegally in certain places where even under the current Ninth Circuit Court decision cannot be camped, or whether it's challenges or whether there's significant health issues going on. They will ask us if we are willing to go in with them and do street medicine, and so that they can offer services as they go in to try to engage with folks and move them into different situations. And so we were really concerned about that partnership. And I can imagine that many of you hearing that would be, we don't want to be associated, oh, they're the ones that work for the cops or work with the cops. And what we've been really pleasantly surprised with is an engaging and having active conversation with the people we serve and the people that we're seeing there. And we're just with them because it's about safety when we're out in these distance places. We want to make sure that we can serve people well. And they're like, hey, I get it. I'm just glad you're here. I've got this thing, and so it turned into another opportunity for engagement. But it's really because we have all been coming together in this rural community with low resources. Rural communities increasingly are experiencing challenges around houselessness. It's been a rapidly growing problem in the rural parts of the country as well as in urban areas. And it was the willingness of the community partners to come together and to begin to try to talk and engage in how can we proactively change this scene. Next, please. So there are a lot of challenges in working this in our particular area, and they're challenges that are both common to people who are doing this kind of work, no matter where you are. And then some of them are kind of unique to our area. As I mentioned before, mental and behavioral health issues create serious barriers to meeting some of the measures and the various things that we want to do. As I mentioned before, some 78% of the people that we serve, we have 800 patients experiencing homelessness associated with our homeless services unit that they see for multiple thousands of visits a year. The mental and behavioral health issues that many of the folks struggle with often impede them being able to, proactively engage on their own behalf with us, with other partners, working with folks to try to create the best environment we can and the most trusting relationships that we can, so that we can not only help them walk through services with us, but we are often part of how they end up engaging with services with other agencies to get those things that they need, whether it's healthcare coverage or food resources, or get them into housing. Our licensed clinical social worker, before coming to us, she actually worked both with the county mental health department and had worked previously with probation and parole, and brings a very real sense of what it's like in those settings to try to help us work with people and to help create an environment in which they feel safe to engage with us, to know that we don't judge, that we are there to offer whatever they want and whatever they are willing to engage with, and to go with them to many of their other appointments wherever we can, where they may need an advocate with them. Our MSW, social work case manager, does the same. There's a real lack of community resources, and transportation particularly is challenging. Public transportation is very limited here. While state Medicaid in California pays for transportation services and will pay individual agencies to transport folks, it has not worked well up in this area. We have 3 Uber drivers, for example, in the whole area, and they have lots of higher paying clientele. And so when it comes to a push to shove, hey, somebody's calling for a ride, or I can go pick up this client of Open Door or whoever and transport them and get the amount I can get from Medicaid for doing that, they go with the other client. And so really working with folks to try to do that, we are beginning to explore ways of changing that game. Again, there's no urgent care for Medicaid. So it's either the emergency department up here, which is great if something's falling off or falling out, and then there's us. And that gap in between, we have decided to create a related service, again, our acute care center, to be able to meet that need, and to make it friendly and open, and where it will work for those experiencing houselessness. And one of the things that they need is not an appointment, but a chance to walk in and be served. And we use our triage RN to be able to give them immediate access to services wherever we can, and to kind of prioritize that, because those are the folks that if we can't serve them now, they may not be able to engage. Also using our team members to help them do that. Unstable local conditions. Also, we have a lot of controversy, new laws being put into place about where people can be and where they cannot be. And those things have yet to be court tested against the Ninth Circuit Court decision, but there's a lot of moving people around, and increasingly folks are moving farther and farther out into unincorporated and difficult to reach areas, actual green belts outside of town, and conditions where we're finding it harder to get to them. The other thing, of course, is a mobile and a street reach team. Love the concept of patient-centered medical home. We want to engage people. We want to be available to them when they need care, and we cannot be everywhere at once. And because this is becoming geographically more and more spread out, we're finding the challenge of getting to people and really offering them a medical home. Homeless, and also we're seeing increase among for women, families with children, and also the fastest growing group of homelessness here is actually people over the age of 65. And we're finding that people lose a life partner, they're sliding quietly into homelessness with no one to catch them, and they have different needs and different problems, and many of them are falling into homelessness with absolutely no skills of how to live in that environment or how to navigate that. Next, please. So along with that, these things, the great things about challenges is they also create new opportunities, chance for solutions. Another thing that creates those things is networking with folks like yourself, hearing what you're doing in your area, particularly the National Health Healthcare for the Homeless Council and its conventions are great places for doing that. But again, the change that COVID really brought is this new ability in California to bill for telemedicine services in a different way, to be able to offer them and bill for them and to be able to be reimbursed and keep things sustainable. And that has allowed us to have a further reach, particularly into hotels, shelters, and other unique settings inside someone's RV. One of the times we had our nurse really go into the RV that they lived that was no longer mobile, that was broken down in a vacant lot very far from where services were easily obtainable. The person in the vehicle was not mobile themselves and not ambulatory, and we were able to actually serve them in there, get a provider's eyes in there when we couldn't get the provider in person, follow through, and we were eventually able to help them in multiple ways, including to be able to get their ability to walk back, on top of getting them able to get connected to services where they could move from a broken down RV into better circumstances. Using backpack medicine to really reach out into areas that are not accessible. One north of one of the towns, which is right on the border of where the city is responsible and the county is responsible, is a river and a green belt along the river. And there are folks living on either side of that river, really quite far from reach of roads or anything else. And being able to take backpacks with materials, reach out to folks, encourage some that can come farther in to either come to the van to get them in connection with other services, but to begin the process of engagement and to offer what we can while we're out there. Next, please. Also, really turning from appointments and that kind of concept to simply open access scheduling to really at both our clinic and our mobile and with street medicine. If you're talking to us, your appointment is started. If you want services now, okay, great. We'll rotate you in. You know, sometimes it's first come, first serve, and that there are people in line ahead of you, but that we can engage. And in the meantime, we can give you some food. You need any other supplies? Hey, is there anything going on the case management side, or is there something bothering you that that Karen, our LCSW, can talk to you about? Giving folks also things to do and actual social engagement while they're waiting has been a big key for us in helping people like build that relationship of trust. The time that the team takes to just talk the way you would talk to anyone. Hey, what's going on? Yeah, it's kind of cool today, et cetera, whatever. And to be able to have that conversation makes a huge change and has really helped us understand the importance of social engagement in creating the rest of the relationship we need. Next, please. Also, of course, I mentioned earlier about our acute care center. Next. Transporting patients with our own vehicle, that has been key, and we're wanting to expand that. So we've been looking at other agencies who've gone there. We can get paid by Medicaid in our state to transport people. I'm putting it to our organization. We're looking into what would it cost, what would it look like if we became a transporter for our patients, starting with the homeless, starting with our Medicaid patients, not just to appointments that benefit us, but that's something that, where they make it to ours, but to everything else that they need. So really looking at whether being a transportation provider, because there's many, many housing providers. And that's one of the things we looked at. Do we get into housing? Maybe this is the way we get directly into housing. Many agencies have, and it's amazing to see the work that has been done on that. And we're inspired by it. And yet we have really, really, really able, sharp operators in the housing community who have been really working to expand inventory. We have had hundreds and hundreds of units added in the last 2 years in our community to begin to meet that. And we began to realize as an organization, as we talk to our board, as we talk to our patients, we don't need to do that. We need to partner well with those people and support them in their work. But one of the places that hasn't been filled in is this gap in transportation, being able to get people from where they are to where they need to go and where they want to go, to be able to engage with resources and other things. There's going to also the growing community projects and our direct involvement in offering medical, our piece of the case management and social work services, behavioral health services, and so on in a new day use center that will be opening up here. And of course, Project Home Key, these places that are being converted into housing units and literally bringing our services inside. As I mentioned before, we do a truly integrated medicine model here. So all of our visits happen with the involvement of the case manager, social work case manager, substance abuse providers, and our behavioral health person, our LCSW, very often having them there and everybody going, so which of us can help you today? Maybe it's all of us. And often facilitating those visits, because they very often, for many of the people we work with, they can't fully identify all of their need in the moment. And then there's the medical need that we need to meet. There's the behavioral health need. They may need that assistance just to be able to navigate a visit with us. And so having those folks be core present together and to kind of present that you always have this whole group of people available to you if you want them. And they can say, no, I don't need anything from them. I just want to talk to you. And guess what? That's where we go. Okay, next, please. So really, with all of that, we have many similarities with the program at Father Joe's, and then we have many things that are different for us. Part of it is because of the difference between the urban and the rural context. Part of it is the difference and the unique environments. And as I've discussed things with homeless providers across the United States, I have noticed that every environment is unique to itself, the challenges that are going on, what's happening with those who are experiencing homelessness in the community, where they are, what circumstances, what resources available. There's a lot of variability. And so for us, really putting it together, creating relationships of trust, not just with those we serve, but with our fellow service providers within the community, creating relationships with hospital, housing providers, food providers, and so on, and to try to create that and to look for the gaps that we can and should fill, and to support others in stepping up into those gaps as well, is what has created the program that we have today that is, again, still evolving in the face of all of that. Thank you so much for the chance to talk about what we've learned, the challenges that we're facing, and for allowing me to be here and present with you today.
Thank you, Thomas, so much. We really appreciate you taking a chunk of your day and spending it with us. That really fantastic work that both of your agencies are doing. We're really excited to showcase and highlight that. I guess we want to sort of open it up for the larger audience to, if you want to come off mute, and if you have any questions, or if you want to use the chat function to get your burning questions to Thomas or to Maylee. Oh, this is when everyone goes radio silent.
And we are fortunate to have about 20 minutes left of our scheduled time. So we really want to make sure we're using this opportunity for any of you all, if you do have questions about either how to bolster your existing programs, or if you're considering building a new program, or if this is a new idea, don't be shy. Come off mute. Let's have a conversation. We're very fortunate to have such experts in-house today to answer some of those questions.
I would, while we're waiting for questions, I hate to jump in here, but I would like, because I'm in San Diego, as is Maylee, would love to have you talk a little bit more about Father Joe's Villages. For those who are not from San Diego, you guys are, if not the largest, one of the largest supportive housers in our region, have been a pioneer for many years, and would really love to hear you talk more about the housing component of your larger agency and how your street medicine fits in with the housing.
Yeah, I would love to. So yeah, so Father Joe's Villages is a nonprofit organization. It wasn't before, but it became, it had that, it became that business status when things started to change a little bit. So the roots of it are that we had a hustler priest. His name was Father Joe. And really, the way he engaged with people out on the streets was to give them peanut butter and jelly sandwiches. And he was known as a hustler because he was really good at getting funding for the things that are needed. And so really it grew out of a passionate individual whose name is now on the organization, who passed away last year. But that, the philosophy of that individual has really carried through the organization of having that, that concept of, like if you're trying to support people, there's money out there to, to support these individuals, right? And build the programs, build the support for people. And the other philosophy around that is that we treat people with dignity. A lot of our village around here is not like, it doesn't have signage that this is a homeless provider. And we want to keep it that way so that individuals feel comfortable accessing our services and don't feel stigmatized by, such type of signage, and so we are nestled within the east part of downtown. We do have a lot more encampments now. I think the current number is, oh God, I forget the current number, but it's a lot. We provide all kinds of services. So we manage the operations for some of the largest shelters within the county, including Golden Hall and some of the shelters at the PMC, which is the Paul Mirabelli Center. I can never say the whole name right. So we manage the operations, and the funding for those shelters comes from the San Diego Housing Commission. And the other thing is that we build buildings that are permanent supported housing buildings. We just built a new one called St. Teresa of Calcutta Villa, and that is housing 400 plus individuals in there. And we have tenant services that continues to support those individuals as they transition into housing. Because as we all know, there's relapse to that too, because of the challenges of being in a structured environment. And we're working on getting a community nurse out there as well. We also have therapeutic childcare program, which is like a school. It's a daycare school that is trauma-informed approach. And even our medical director's daughter goes there, which is great. And one of the coolest things about that program, there's like a guest shop. It looks like a guest shop at a hotel, and it's so cute, but it has like these little items that the kids can purchase, and they get points, right? They get points for learning certain things and learning value, right? Like the value exchange. And those are big skills for them to learn. And so they can go to the shop and use their points to buy, a toy that they want. We also have psychiatric services. We have behavioral health services. We have alcohol and other drug counseling. We have an outreach team. We have a day center. We have a clinic, an FQHC, which we only provide healthcare services to homeless individuals. We have a lab. We use Quest Labs. What else we have? There's like a lot, and we have a warehouse, and we have we have multiple retail stores. So we have thrift stores and stuff, and those look so much fun. I mean, I always envy the people that get to decorate the storefronts. But yeah, we have a lot going on here.
Yeah, and that's, I really wanted to have you share that with the audience, right? Particularly the housing, right? That the St. Teresa building is newly minted. I think it opened probably 6 months ago. To add a building that is housing 400 individuals is really astonishing for San Diego. I think for anywhere, but particularly for San Diego, where developments get challenged, particularly permanent supportive housing developments get challenged left and right most of the time. Thank you for sharing.
I believe we have another question in the chat from Carla Boho. And she writes, for the times you plan to submit a bill by adding people to your EHR schedule, if they request a medical visit, how do you manage getting the information about who the payer is or get their billing info in a way that doesn't seem to make that info is the only priority?
Well, when we're out on the streets, we do take some of our laptops. And it could be a sensitive space, but we have an outreach medical assistant who's been working at Father Joe's Village for about 11 years, and she used to work up at the front, as registration and verifying people's insurances. And so she's got a skill set that is not easily found, and that skill set is really gently asking for things like social security number, things that are really sensitive to some people. So really there's a finesse to how she asks. But yeah, we do verify insurance out there. But if we don't, if we're not able to, like maybe the circumstances are weird, we have an ability to dispense medicine as well. We are partnered up with PDRX to be able to dispense medicines, and they charge a very low rate for some of the medicines that we give out, like doxycyclines, some cephalosporins, I'm sorry, Keflex, I cannot think right now, but Bactrim, those things that are very common out there.
For us, it's a combination of things. I love what was said about those people with those unique skill sets and like just kind of talking to people and edging them in. But one of the things is too, like I'm also, I get to do less of it than I used to as they've added more to my plate, but I am one of the people who's out actually doing outreach in the community and talking to people that are experiencing homelessness. And in doing that, I make sure everyone knows, and I say, spread the word. It doesn't cost you anything. You don't have to have healthcare coverage. You don't have to tell us about it if you do. We kind of figure things out. Some people, we look it up and we, eventually get proof of information. In the meantime, we still do services. We never let that be a barrier. And a lot of the people who come and engage us, who haven't engaged us before, heard about us from someone else who's experiencing houselessness. One thing is like in recovery, we have this concept of one alcoholic helping another. Well, I see the same thing out there in houselessness, the concern for their fellows and their community. And that's one of the things that I want to stress here is that in most places that I've encountered, and certainly here locally, the homeless, they're a community of people. They see themselves as a community. They have relationships with each other, and that relationship and that talking to people about that, them knowing that they can come to us, and if they got that going on, great, because it helps support us, and they're actively interested in supporting us. They begin to realize that we are part of their world and part of their community, and they want us to be there. And so they can contribute that information when they can or will. We are also able to get them connected to those coverages when they're interested. And it's like, hey, are you interested? You're not? Okay, great. We'll see you anyhow. Doesn't matter. We move on very quickly. And that, yep, okay, no problem response has really spread by word of mouth. And just the fact that it's not a problem and that we're not acting concerned about it means people are way more willing to engage and talk to us about it, simply because it's not a thing. And I think that that's the big part of it, is having a culture in our team of approaching this. Like at the end of the day, we never deny anybody ability to get services based on ability to pay. And we lead with that. That's what we want people to know about us.
Want to leave it open in case we have more questions, and certainly continue to drop them in the chat, or feel free to come off of mute if folks would like. If you have other questions that you'd prefer to ask in person, keep them coming. We really appreciate this perspective that everyone is bringing. And there's certainly so much more that we could dive into, specifically about, connections to housing, specifically your relationship with your COC. There's so many things that we really could dive into. So don't be shy with your questions in our last 10 minutes together.
One of the things our street health team is going to start doing is creating a board with like little Betty stickers. Betty is our van, and little Betty stickers every time we get someone into shelter. Because there are weeks that, like our outreach worker is insane, and she'll get like 5 people into shelter. I'm like, you have a lot of connections, and I'm not quite sure who you're connected to, but that's awesome. So it's pretty cool to see, the individuals that we serve out there are getting into shelter, and we don't finish our work there. If they're in one of our shelters, we try to follow up with them and check in with them. make sure they're okay. We keep holding hands, you know? We don't want to let them go. Like we keep track of everyone. We have our eyes on everyone that we serve out there. It's kind of a neat thing.
Well, and I'd say to Thomas's point earlier too, that's part of the beauty of having kind of mobile services and outreach services that are embedded within an FQHC.
Yeah.
I used to work for local family health centers of San Diego, managing mobile units. And that was very key is, okay, we will see you on our van, but we really would love to get you established within one of our clinic sites where it can be much more full service. So you have that backing and understanding, you know, to the one point, you know, some people were attempting to use the mobile van as their medical home, even though we would really try to encourage them to take advantage of the fuller array of services. But at the end of the day, that you're still able to provide that mobile or street outreach service while someone is in shelter. That's fantastic.
Right. And you know, it's really following people through the continuum, because we want to make sure that we're there for them when they might experience some trauma. For example, we were able to get an individual into recuperative care. This individual has spinal stenosis and is really suffering from a lot of pain. He has been using alcohol to kind of numb that pain and get through it. But really what this individual needs is to be in recuperative care. And, you know, he's been very kind to the street health team. You know, there's been really great rapport. And the day of his interview, he had to interview with the nurse, the intake nurse, and then also had to interview with the residential team. And the interview with the nurse went well because she was already familiar with this individual. But later on, he went over to residential and interviewed with that individual, and he got triggered. And I think that because they haven't had really a good understanding of who he is and like had just met him, and he had just asked, could I go outside for a cigarette? And they said no, forgetting that he had been in interviews for the whole morning, you know, like getting him set up to be in recuperative care. And he was tired and he just needed a break. And unfortunately, that team member wasn't being mindful of, you know, this person could use a cigarette right now. Like, that's okay. It's not a big deal. So it triggered him, and it also triggered the residential team. Like, oh my God, he's belligerent. No, I'm like, no, he's not. Give him another chance. We will walk him to there. We will be with him so that he feels comfortable and supported, and you can advocate for him, right? So always being that advocate that goes along with that patient's journey is also critical.
And we have another question from Donna in the chat. How did you start setting up your recuperative care program? Was it already in place prior to your street medicine program?
It was not. It took an entire year and a half to set up the first contract for the recuperative care program. And you know, also trying to advertise to like ERs and places that might use them has been, you know, challenging. And then there's the other component where our residential team has to be kind of set up and trained and to really understand the payment model there and the criteria involved with running a recuperative care program. So it took a year and a half of discussions with the health plan, but also with residential, and it's an ongoing thing, and it's an ongoing process of building that program. Honestly, like, you know, every week we have about 7 beds filled, and we have a total of 28. And my guess is that we're lacking in staff. We're not fully understanding all the criteria for all the health plans, all the 7 health plans that we have to figure out. People don't know about it. there's a lot of back and forth when people get into intake, a lot of back and forth, a lot of assessment. And, residential teams probably need a little more training on dealing with some of the more health related kind of things. But, I always say, like, they can come down to the clinic and come see us if they need support. But yeah, it's a lot of like just figuring it out. It's not an easy program yet. It's not swimming yet. It's kind of like treading water. But it is running, but we're still learning from the process.
And I wonder if you could speak a little bit about the funding sources for that particular program. Donna had a follow-up question on that.
Actually, that has not been funded. That's been just an extension of the residential team that already exists in that particular building. There was an area that wasn't utilized. And so it's really just using that team that's already there. But yeah, we probably need to expand it, and that expansion should, it needs some money in there to really expand. So I think one of the positions is funded now. We found a manager who's also doing the CalAIM stuff in California. And so that person will have kind of 1 foot in CalAIM and 1 foot in recuperative care. And I think that one was a grant funded one, but I'm not totally sure.
Well, I think we have about 2 minutes until 3 o'clock. So if we have any last minute questions, feel free to bring them in now. Otherwise, I just want to say thank you both so much for your time, and for all of our participants. This has been a really great conversation, and to keep up the good work, because this is really, I think, really great for us to be able to highlight some of these national programs, some of these best practices for the benefit of our audience. So thank you so much for letting us trespass on your time.
Yeah, thank you so much.
Thank you.
And we will be putting up a poll just very quick. Please let us know how we did. Your feedback is so important to us. It helps us to tailor our content for future HRSA sponsored training and technical assistance. I will be sending out a follow-up link to all of our participants with a link to the recording of this session, as well as contact information if you are interested in direct technical assistance one-on-one with your team and our team. This is provided, of course, at no cost to you, thanks to HRSA. So please let us know if that's something that you'd be interested in, and we're happy to set that up at any time that's most convenient for you all. And thank you all so much.
Yes, thank you.
Thank you.
Everyone has a really great day. Bye now.
Bye, Melee. Thank you.
Thank you, Melee. That was beautiful. That was an amazing presentation.
I learned a lot from you. Thank you, Thomas. I learned a lot about what you guys are doing. This is cool. I had no idea.
It goes both ways. And, I can tell you, I really pushed hard at my organization for a number of years to really step into the whole housing thing, though I can understand why we're where we are up here. And, it's very interesting about your recuperative, program, because I'd love, to be able to do that. We have to work really actively with community partners, both here and in other counties. Because of the lack of bed availability, that when we have folks experiencing houselessness who have had a significant, physical trauma or whatever, they got healing time that they need. We've had a relationship with a couple of clean and sober houses for bed spacing as they have it available, that we just pay for out of pocket, and then send our teams in to do things and like that. It's just, we decided that it was missional and that we couldn't do it. And we don't have quite the volume situation that you do. The difference with our situation, I think, is one of scale in many ways. You guys are down in an intensely urban area, and while per capita we're easily in the same ballpark, that's much different though when it's really scale in numbers. And there's times where in this current economic situation, that is a different game. But even for us, that's not enough, and that we have to often move people out to another county and then arrange to get them back, because what they want to know before they're agreeable to going and doing recuperative services somewhere is that they're going to be able to get back to where they consider their home.